Uh, Good evening to all of our viewers on Facebook and YouTube. My name is Maurice Elliard. I am standing in for Pastor Daniel Simmons tonight, and I'd like to welcome everyone to what is going to be a presentation full of life-saving information, particularly as it relates to men's health. If you have questions at any point during this presentation, please place your questions in the chat box. Also, I'd like to ask you to share this program with all of the men in your life, fathers, sons, husbands, brothers, uncles. Uh, Information that will be shared could very well save the life of someone that you have here. Prostate cancer is the most common cancer among men, and it is the second leading cause of cancer. However,
So good evening, everyone. Thank you, Mr. Elliard, and I appreciate Pastor Simmons' invitation to join you this evening. I'm going to keep it pretty informal. I'm in my office here in Baltimore, and as mentioned, I'm a medical oncologist, and so when you have cancer, there's three types of doctors that you often are going to see: the surgery doctor, the urologist, the radiation doctor, and then the medical doctor. That's what I am. And my mission has been to develop and evaluate new therapies for urologic malignancies with a primary focus in prostate cancer. And so when invited to speak, was asked to sort of cover a range from early disease to late disease and where we might be conducting research. So I'm going to just talk briefly and then have you all post questions in the chat, and I'm going to be happy to answer those. So I'll go ahead and get started. And I think it's already mentioned, prostate cancer is a common cancer. It's the most common cancer diagnosed in men. Over 220,000 men are going to get diagnosed in the United States this year. There's been a lot of controversy about whether we should screen and go looking for prostate cancer because much of the data says that even if you find prostate cancer, most men are going to die of something else, or it's not going to affect their overall survival. So why do we need to talk about it? But I think it's the fear and concern about what this cancer does to men if they have it and it spreads, and sort of what dying from it may be like. So I think the word cancer always has a lot of meaning to it, fear to it, and concerns. And so really, there is this tension about should I know, should I find out if I have cancer or not? and particularly prostate cancer is one where, because it's really common, one autopsy study out of Detroit looking at men that when they died, how many of them had prostate cancer. And by age 80, almost 80% of the men, if you look in their prostate, have prostate cancer. The issue is whether that prostate cancer ever is going to be an issue in one's life is a question. And so when we started screening heavily in the 1990s and the 2000s, that's where the concern came from, that we were diagnosing men and not really changing how they live, in some ways harming their quality of life by offering surgery or radiation that sort of affects many things, such as sexual function, bowel and bladder function. So folks are always concerned about that. And so that movement, when we found so many cancers each year, has led to that we're at a point now when we actually get a diagnosis of cancer, we can look at it under the microscope and suggest and make recommendations to an individual as to whether they even need therapy. So we often find a very low grade or a cancer that may not even be cancer behavior-wise, that we would suggest to men that they watch and wait, or that we don't really offer therapy, knowing that if we did have to offer therapy because it changed, that we could still offer therapy that would improve their survival or overall outcome. But we do want to find those individuals who've got the more aggressive types of cancer that are more likely to spread and go to other organs in the body, particularly bone or lymph nodes. And those are the areas that we sort of are really doing and focusing a lot of research about our therapies, finding and diagnosing the cancer early. So when we look at screening, who do we want to screen? Screening is actually testing men who have no symptoms to see whether they have this common cancer. Screening is not somebody who has difficulty with passing their water or urinating, folks who are having changes in the quality of their erections, men who sort of are up multiple times a night peeing, noting blood in their urine. That's no longer screening. That is actually, why do you have a problem? And one of those problems could be prostate cancer. More often than not, there's other things like kidney stones or bladder stones, or the prostate's grown just too big. As we get older, it gets bigger, makes your bladder want to push the urine out, so you feel like you got to go more often. And so we're really listening for things that sort of could be prostate cancer. And some of those symptoms that I just described are a part of it, as well as things related to pain, bone pain, back pain, rib pain. Those are also things that would suggest that maybe the cancer is more spread, or swelling of the legs because you have swollen glands in one's pelvis that block the blood flow. So those would be suggestions that the cancer is fairly far along. So we do screen, however, because in the aging male population, we know that this cancer becomes more common as you age. So the recommendations are for screening starting at age 50 in the white male population. And in the black male population, they actually start suggesting as early as age 40. If you have a family member who's had prostate cancer, and that would be a father, a brother, or a son, then we would also recommend at an early age to start looking by checking PSAs. And if they're changing, so PSA is a blood test that sort of is made by prostates. And when you have prostate cancer, those levels can be high. And if they go up, that suggests that there's a greater likelihood that we may find cancer if we proceed with looking at that diagnosis. So if you have an elevated PSA or it's rising even within the normal range, if you've got a family history and it's rising, most of the time men will get an MRI. That's an imaging test that's sort of looking at the prostate to see what's the likelihood if you stick a needle in there that they're going to find cancer. And then really the diagnosis is made by sticking needles into the prostate and seeing what the cancer looks like and deciding how aggressive it is by what the cells look like under the microscope. So when they do that, they're looking at a scale of aggressiveness on a scale of 1 to 5, 5 being the most aggressive. And they look at the most common pattern in the tissue and the second most common pattern. So every specimen gets 2 numbers. You add them together, so that's going to end up being on a scale of 2 to 10, with a cancer that's a 10 being the most aggressive. We consider aggressive 8, 9, or 10, and that's cancer that when we find it in the prostate gland, there is a higher likelihood that these are cancer cells that have left or may spread to other organs when we make the diagnosis. And yet when we image or look at scans, we can't find the cancer out there, but that's what accounts for why men have cancer to come back despite having surgery or radiation, which is the main therapy for people with local cancer. So that's the local portion of it. And for the most part, when you look at radiation or surgery, they're equal in their ability to cure people, because if the cancer is curable, they're equally effective. We do know a little bit of sort of some folks who are older or have more aggressive cancer. We tend to favor radiation along with using hormone therapy. And in this case, hormone therapies are drugs or surgery that basically make men have no testosterone. So that would be removing the testicles or giving medicines that fool the brain into thinking there's too much testosterone, and it shuts the whole system down so men have no testosterone, and that chokes and kills the cancer, but unfortunately doesn't kill all the cancer cells, and that's why we have to use radiation or other drugs. And that's where the research comes in, because if we do find men with very high risk cancer, we tend to sort of want to add more therapies to that. And with that, we're able to show that we are able to have better outcomes, cure more men. If we can't cure them, they live longer and have longer periods of time without disease before we have to add in more systemic treatments. So what we've really been focusing on, better ways to diagnose the cancer. Are there other tests than PSA? We've looked at a lot about imaging. Can we find the cancer in an early stage? And there's been a lot of work with PET scans finding cancer earlier, which help us guide and help us focus on whether local therapy is going to be enough or whether we have to add in drug therapy on top of that to improve outcomes. And then where I spend most of my time is looking at drug therapy, which is a part of new drugs, new targets, new reasons how cancer gets around our drugs. So we have to figure out even smarter drugs. And so from that is where we've actually been adding drugs to our armamentarium over the last 12, 13 years. Most of the drug approvals for prostate cancer have been since 2010. One was approved, a chemotherapy, in 2004. So those are all ones now that sort of extend how long men live with prostate cancer. And so in many ways, this cancer does change and grow slowly as compared to cancers of pancreas or the lung. So I tell men all the time that I'm going to grow old with you, because many times we're able to slow the cancer, even though we may not cure it. We're able to kick the can down the road, and folks keep living, what we hope is a good life. And hopefully, as they get older, unfortunately, many more things try to get rid of them as well. So we're all focused on making sure that their quality of life is as good as possible for as long as possible when we're picking on therapies. Um, so, I was asked to talk more about the research. So we really do focus on the hormones and sort of testosterone and how it works in cancer cells. In prostate cancer, it is the driver of the disease. So by getting rid of it, we do kill most of it. And what we've learned over time is cancer cells themselves, if they have no testosterone, because they're trying to grab it from the blood supply, and if it's not in the bloodstream, they make it themselves. So they all have the building blocks in the cell itself to make testosterone. And that's where the newest drugs have come in to block that, get rid of the building blocks, or keep that testosterone that they make from transferring to the middle of the cell where all the activity is. We've learned more recently about drugs that break down the receptor or the keyhole that testosterone uses to make the cancer grow. We've got new drugs that sort of make damage to the DNA of cancer cells, not normal cells, which cause them to die. So we've got liquid radiation drugs that go in the bloodstream now that sort of extend how long people live. And the most recent drug we have is that we've been able to make like a smart bomb that sort of we know what cancer cells make on their surface, and we deliver a poison, in this case radiation, that gloms onto that marker on the surface and delivers the radiation directly to the cancer cell and able to kill that. So that has been recently approved in the last couple of months. It doesn't cure people, but it does extend how long people live. So those are sort of the types of drugs, along with chemotherapy, which when cancer cells are dividing, chemotherapy kills dividing cells. And unfortunately, or fortunately, cancer cells aren't able to repair themselves, and that's why chemotherapy works. Whereas normal cells like our hair and our gut, they can regenerate, and so the side effects are limited as they heal, whereas the cancer cells, we hope we're killing them. So that's sort of in broad strokes, the approach. I'm going to ask Hyacinth to bring up one slide so that we can show you sort of what the natural history looks like of prostate cancer. And if we show that slide, I can show you where people move forward. So the first box there is about clinically localized. That their cancer keeps showing PSA that's rising, we've got to make decisions about therapy based on whether we can see the cancer or we can't see the cancer. And it's very common that for many years, we tell the individual they have cancer, but we can't see it. And then the issue is, do we need to treat it or not? And so that is a period of time where men have a lot of anxiety about having cancer and oftentimes being told not to do anything. And then where many of the drugs that I just mentioned are focused on is when the cancer comes back, we can see it, it may cause symptoms, and that's when we start the many drugs that I just mentioned. So Some men start at the very beginning with localized cancer, and unfortunately, they're not cured, and they go through that whole timeline. Much of that data says that the average man who has a recurrence after surgery lives another 16 years. So sometimes that seems reasonable. That's why we use the word slow. Unfortunately, sometimes if you're 50 plus 16, you get to 66 and you feel cheated. If you're 76 and you get 66, you're going to be 92, and those folks feel like, why did you keep me alive this long? So everybody's got a different view sometimes, and that's why we have to tailor and make sure we adjust what we do based on how that individual is doing, what's other illnesses or chronic diseases they may have, what issues may be facing them, and what other aspects as we're making treatment. So that's how we tailor our treatments and our recommendations. So I'll stop there, and I can already see that a number of you have started putting chat comments in. So I'll stop there with my just opening comments, and we can look into some of these questions that you've brought up. So
Are several questions in the chat. And the first question is, does early age diagnosis of prostate cancer have any thing to do with how aggressive the cancer is likely to be?
Yeah, I would say for the most part, no. That prostate cancer behaves the same whether it's diagnosed early or late. There is some data that says maybe the cancer in very elderly men, 80 or greater, may end up being slow disease, but that hasn't borne out. The problem with cancer in the young individual, 50s or late 40s, is that if we don't cure it, the individual has enough life expectancy that we're going to likely see the entire thing play out, so that it does come back. We do treat it, it comes back, and we treat it, and it keeps coming back, and men can die of that disease. Whereas an older individual, I'll pick 75 as an age, they may have other things happen to them, like a heart attack or a stroke or kidney failure, that's not related to cancer, that they die from, so it doesn't look like they died of their cancer, even though they still had it when they passed. So that's why sometimes in the younger individual, it looks more aggressive. But the young people can be cured just as much as it is in the older. But if they're not cured, we tend to see the whole thing play out. You're back on mute.
Okay, I think I've been unmuted now. Can you hear me?
I can, yes, thanks.
Okay, all right. You talked about the importance of, diagnosing the cancers early. Let's say a man is diagnosed and he has prostate cancer. Is there any way of differentiating between whether it's going to be a less aggressive or more aggressive type of cancer?
Yes, unfortunately, we've been able to sort of answer that question. So by looking at the tissue under the microscope, and then there are tests that look at some of the genes behind cancer that also give us a sense of how likely is this cancer going to be aggressive. So just its appearance is enough. So when I was using that scoring system earlier, someone who comes in with a Gleason 6, there's controversy as to whether or not that's going to be even behave like cancer. That is, it has such a low likelihood of leaving the prostate and going other places, that may be cancer that we can sit on, that we can tell the man that he's got cancer. We may biopsy, we may check PSA, and if it changes, then we can offer therapy and let men live a normal life without having surgery or radiation. That's sometimes where we do some other blood test where we can confirm that this cancer looks like it's going to behave well, by saying it's not going to spread, it's going to stay local, it's not going to affect the other organs. And so that's where we step back. The problem is, again, that age versus old, young versus old, we tend not to watch the 50-year-old guy and say, hey, we're going to just, you got Gleason 6. We don't think it's all that important. We're going to just watch it. And again, because that individual technically has another 25, 30 years of possible life expectancy for that cancer to come back, those men are often offered local therapy. It's when you get into your mid 60s, early 60s, that we start sort of taking that Gleason 6 number and saying, maybe you don't need to do anything, we should just watch you. But if the cancer has Gleason 7, 8, 9, or 10, that's always going to be sort of an indication that we should probably do something, whether that be surgery, radiation, or definitely scanning or imaging to make sure that it hasn't spread, because we would do other approaches from that. So we get a lot of information by looking at it under the microscope, sending other tests so that we can guide men in the right direction in terms of that sort of things that are going to maintain their quality of life, hopefully keep their erections intact and their control of their bladder, urinary bladder. And those are the reasons why we often will hold or defer therapy unless we really have to, based on sort of how aggressive it looks under the microscope.
Okay. All right. Thank you. Several questions have come in about risk factors for developing prostate cancer. And one in particular asked about whether diet or other lifestyle changes one might want to make in order to minimize the likelihood of developing prostate cancer.
Yeah, I think the strongest risk factor is a family history. So that's important to know, and that changes over time. So again, a father, brother, son, unfortunately, sometimes younger folks than you can have it. So we're always tracking it. That's the biggest risk factor. Other risk factors are, again, some family syndromes. There's a couple genes that associated with breast cancer, pancreas cancer, and even sometimes brain tumors, that although it's not prostate cancer, if there's a number of people in the family who have those types of cancers, one may be at a higher risk of prostate cancer. There is data that the American diet is not friendly to our prostates. So there's data that, Asian men growing up in China or Japan have far less prostate cancer aggressiveness than men in the US. They seem to have the same amount if they biopsied them, but how they behave is better. And so they think that may be some of the diet. They eat more fish. They eat other leaner proteins. They don't use grills as much as we do. So when we look at the American diet, we're eating a lot of animal fat. We eat a lot of grilled meat that sort of have possible carcinogens. We eat less fruits and vegetables. So that is where we sort of counsel men who have prostate cancer. We do suggest more watching your weight, staying physically active, and really focusing more like on a Mediterranean type diet, which is low in animal fat, leaner cuts of meat, eating more fish. Fish a couple times a week can reduce your risk of heart disease, reduce your risk of prostate cancer. We recommend men eat more fruits and vegetables. And my rule of thumb is if it's blue or red, it's good for your prostate. So blueberries, raspberries, tomatoes, pomegranates, watermelon, tomatoes, if I haven't said that, all of those are sort of rich in the right sorts of nutrients that can protect the prostate. Things grown in the ground like onions, garlic, carrots have a lot of natural selenium. So those are things that we recommend. Almonds, walnuts, Brazil nuts are also have good oils in them that are similar to taking fish. So like my family, we don't like a lot of fish. So we eat a lot of nuts, beans. So those are all sorts of things that seem very natural. Also, all of those reduce your risk of heart disease. So if it's good for your heart, it's probably good for slowing prostate cancer down or keeping you from getting it. So lower weight, although men who are heavier set may have a later diagnosis of prostate cancer, because if we have extra weight, that may sometimes lower testosterone, and in some ways that maybe slow cancer down. And so there is concern about men that have extra pounds on board may have more aggressive cancers when it's diagnosed because it's been put off for a while. Although there is data that says if you get diagnosed with cancer and you're able to lose weight or keep your weight down, it also may be associated with a better outcome. So we do talk about diet, exercise. Many of our treatments, when you start hormones, when you don't have testosterone, it changes a man's metabolism and they gain 15, 20 pounds. So if you don't have the room to gain that, you can get into trouble with diabetes, high blood pressure, high cholesterol. Fortunately, men with prostate cancer do get older. And if you smoked, then, we worry about people's risk for heart attacks. So we do counsel men about keeping their heart healthy along with watching issues for their prostate.
Okay. All right. Very good. Another question has to do with treatment options once a man has been diagnosed with cancer. Is it generally, and you talked about some of the drugs that are showing a lot of promise for treatment. In terms of, I guess, the order, are drugs generally used prior to surgical procedures to deal with prostate cancer?
So if someone has local cancer of the prostate, it's usually surgery or radiation. If typically surgery gives you a lot of data about, did the cancer leave the gland? Is it local? Did it spread north to the seminal vesicles? Did it invade the urine tube? Did it go to the local lymph nodes? And if we see some of those factors, then we're going to need to add in radiation either after surgery or down the road if we can confirm that the cancer came back. So in that case, it's often surgery, then radiation. And if we use radiation, we do often use the hormone treatments along with it. If a man chooses radiation, again, for the lower aggressive cancers, radiation by itself may be enough. If they have cancer that looks more aggressive under the microscope, that's when we add in the hormones, but we define a period of time. So 6 months to 2 years is sort of what we add to that. And again, data out of Europe says maybe we should intensify that and even add more drugs if we're going to use radiation to get the best outcomes. So that's really more the local part of it. And it's really the folks that I work with. If their cancer comes back and it's spread and we can see it, we typically do start with hormone treatments, lowering testosterone. And depending on how much cancer we see, depending on how old the individual is, how frail or not frail, that's when we can add in more hormones. So we've got drugs that intensify it. We can add in chemotherapy. And so we often start with 2 drugs at the beginning when we start with advanced cancer that's spread. Excuse me. And then it's really after that we add them in one at a time to see if adding the new drug helps. If a drug's not working, we stop it. And so we are always adjusting based on how the individual's doing.
Okay. We have another question. Will age, general health, stage of the cancer, and any other medical conditions limit treatment options?
So age does have a fact, but it's not, like your chronological age, it's your physical age. Do you have other medical problems? We look at sort of what's one's life expectancy given the number of health issues a man has. So like if you call the Metropolitan Life Insurance Company, if you're trying to get a policy at age 75, they would say that you probably have on average 8 or 9 years left to live. So they're trying to make a bet based on giving you insurance, how long they have to give that to you for. But it's that same sort of data that we have about estimating one's life expectancy, because surgery makes sense for men who have at least another 10 years to live. Radiation does too, but can be used in that individual who may have 5 to 10 years to live. And nobody knows, only our maker has a sense of how long we really are going to live. And so we're making estimates, again, based on how well one is. And again, somebody in their 80s may not want all this aggressive therapy because other things may come in the way. Some of our drugs in terms of the hormones can make you more likely to have heart disease. So if you already come in with heart disease, then we sort of are trying to pick and choose therapies that limit that. So those are things that are part of the decision when we're putting it together to make a recommendation. So as a man's making his choice, he knows where we're coming from.
Okay. All right, very good. There is another question regarding screening. You talked about how the number of screenings have gone up over the years. However, there appears to be large segments of the male population that have, yet to be screened. Any suggestions or comments on how we might get more males to get the prostate screening exams?
Yeah, I mean, it's controversial. So, as I said, screening was going through the roof. And when they did big studies, particularly in Sweden, and suggested that by screening, you definitely didn't affect the overall male population and how long they live, because there's so many things that sort of shorten our survival.
Mm-hmm.
So in 2012, the United States Public Health Service suggested that we shouldn't screen anymore. And so for 6 years, the recommendation is don't get screening. So that had some doctors in a quandary about, should I offer it? Should I not offer it? And some men say, hey, they don't care. If I don't get screened, they don't think it's going to affect how long I live. And what the data showed, by not screening, the number of men in America who presented with widespread prostate cancer skyrocketed. So whereas before the cancers we were finding were local, curable, and sometimes now even telling men, you've got it, but we're going to watch, or you got it, but you got the kind that we got to treat, allowed all that sort of to change back in 2017 back to screening is a conversation you need to have with your doctor, explaining why you're doing it. Why do you want to find out? What are we going to do if we do find out? And again, I'm somebody who sees a lot of prostate cancer, so I think it's common. I see it. I myself, when I turned 50, got my PSA. My sense is if you want to know, if you're concerned about it, you should get it done. I think, our partners want us to know, but, many men are scared because if I have prostate cancer and they do surgery, then I'm not going to have erections. If I have prostate surgery, I may leak and I have to wear pads or diapers. If I have it, I'm going to have hormones. I'm going to be not much of a man. So there's a lot of that stories. And so men decide I'm not going to do it because it's tied in with some things that's sort of what makes us men. And yet, many times when we have cancer and we talk to our partners, they're more happy we're alive than whether or not some of those other issues. And many of our treatments today are much better about making sure that if we do have to have surgery, we're controlling our urine, that there's better opportunities for still having erections. Even though it's more difficult, it's not spontaneous. And some of the things I talked about, our hearts and our health and our diabetes, high blood pressure, which are other factors for causing people to have erectile dysfunction, a lot of that's tied into prostate cancer. So in many ways, even prostate cancer that is chronic or people live a long time, it's like high blood pressure, it's like diabetes, it's deadly, but people are living a normal life with it. And so in those cases is why we do recommend strongly, if you've got a family history, and because Black men have a higher likelihood of finding it, we want to sort of make sure that communities of color are aware of that, can reduce their risk and get screened, so that we hopefully can have improved outcomes if we do find the cancer.
Okay. All right. Very good. There are more questions, Dr. Carducci, but unfortunately, we have run out of time. So I want to thank you on behalf of Mount Zion Baptist Church, our pastor, Dr. Daniel Simmons, and the Southwest Georgia community for sharing very important information with our audience. And we believe that, again, the information is going to play a role in maybe more effective treatments of prostate cancer here in our region. And again, thank you so much for being with us. And again, we wish you much success as you continue to conduct cutting-edge research on prostate cancer treatment.
Great. Well, I thank you for the invitation. And again, anytime that we can talk about even clinical trials or research, that's the other aspect of sort of men participating in their care. For us to find better treatment, sometimes we have to sort of volunteer ourselves to find the new drugs and be allowed them to be tested so that we can make it applicable to all parts of our society.
Okay. All right. Thank you so much.
Thank you so much for your time tonight.
All right. To our viewing audience, thank you so much for joining us. Hopefully you found this information to be very instructive, and we hope that you have gained some knowledge and insights that you can incorporate into your lifestyle again, to maybe reduce the likelihood of developing prostate cancer. And remember that the month of June is Men's Health Month, so encourage all of the men in your lives, again, to get a prostate screening during the month of June. All right, good evening, and we hope to see you again next Wednesday.
Good night.